Hi, everybody. Welcome to our first public health grand rounds, the health and well-being of Philadelphia's children at the College of Physicians of Philadelphia. It's the Public Health and Preventive Medicine section. I am Kristen Rexing. I am assistant professor at LaSalle University, and we're just so excited to have all of you here in our very first virtual COVID-friendly public health grand rounds. So welcome. All right, next slide. We just wanted to kind of give you a little bit of background about the purpose of the Philadelphia Public Health Grand Rounds and kind of lay the groundwork of how this will work in a virtual format. So the purpose of the event is to address important public health issues in the Philadelphia region. We bring in local speakers. We always like to get as many diverse perspectives as possible, from community members to practitioners to clinicians and everyone in between, because we think that what really makes public health so special is how interdisciplinary it is and that there are many of us working to create healthy environments. We also like to generate new ideas and collaborations and strengthen our public health community through these forums that bring our community together. I would like to thank our co-sponsors, the College of Philadelphia, the College of Physicians of Philadelphia, and the Philadelphia Department of Public Health, and also acknowledge a funder, the Independence Foundation. Next, please. So at these grand rounds, this is our first virtual one, so thank you for joining us. It's pretty neat because it actually allows us to kind of open up beyond our time zone. So I know some people are joining us from across the country, so welcome. There are going to be two options open to you. There's a chat feature, and in the chat feature you can share information across the whole community of participants. But if you have specific questions for the panelists, we ask that you put that in the Q&A feature. So if you're looking at your Zoom room, which I'm sure all of you are very familiar with, it's right at the bottom. The presentation is recorded and will be available on our section website in a couple of days. So if you wanted to share it more broadly or revisit some of the information, you'll be able to find it there. Also, an evaluation form will be mailed to you a couple days following the event, and we really encourage you to complete it because we take that feedback and try to always incorporate it moving forward. And the support of the section is brought to you by many people, and we would like to invite you to also support the section. So become a member, and you can see our website for further details. Next slide, please. We'd like to thank all of our institutional sponsors, from the City of Philadelphia Department of Public Health to Arcadia University, Drexel, Haverford, LaSalle, Temple, Thomas Jefferson, the University of Pennsylvania, Westchester, the University of the Sciences, and the Public Health Management Corporation. Next, please. All right, and now I will introduce Dr. Priya Mammen. She's our chair of the section of Public Health and Preventive Medicine.
Hello, everyone. Thank you so much for joining us on our first Public Health Grand Rounds from the College of Physicians for this academic year. We have all been through a bit for the last several months, and I'm excited that we can bring back some of our educational programming and our community engagement programs and projects through this abridged, different format, but I think we've all sort of gotten used to this to some extent. I'm very, very excited about this panel and this presentation. And for this evening, I will be doing two things. As Dr. Rexing mentioned, I'm the chair of the section of Public Health and Preventive Medicine at the College of Physicians. I am myself an emergency physician and a public health specialist. I will be introducing the topic as well as our speakers, but I really want to leave the bulk of the time for our amazing panelists who we're very lucky to have tonight to share their expertise. So moving on. Can we go to next slide, please? This Grand Rounds is built on a report put out by the Philadelphia Department of Public Health called Growing Up Philly. This is actually the first report of its kind from Philadelphia that focuses exclusively on children, and that is from birth through adolescence. There have been other reports from the department focused on more specific age groups or more disease specific or issue specific. This is the first that looks at a broad range. And so I believe in the invitation, there is a link to the report. I encourage all of you to look through it. It is chock full of information. I myself had nothing to do with this report. As everyone can imagine, the Department of Public Health in its entirety is pretty swamped right now, keeping all of us safe and protected in a COVID world. So unfortunately, they couldn't join us. Usually they would be the ones to be presenting their data, but they have given me permission to just kind of show you some of the key ideas that are most relevant to our discussion tonight, as well as that which sort of sets the context for our panelists to develop more. Oh, I'm sorry, I just tried to advance. Please advance slide. So here I just copied the executive summary from Growing Up Philadelphia, or Growing Up Philly. And I will let you read it yourself. It's beautifully written, I think, and gives an overview of really what the report found. But what it does, and this is very, very salient to our role as the section of public health and our role in the city, that really brings together the idea of social determinants of health and all of the things that go into the health and wellness of not just our Philadelphia citizens, but the region and country as a whole. And I think, and you know, Dr. Feemster, who's a pediatrician, could speak to this more, but I think there is perhaps no population that really shows how clearly all of these different environmental exposures and contexts in which we live and grow has a significant impact on health than children. Because for the most part, anything other than genetic predispositions and certain kinds of malignancies and things like that, really children are all born with the same biology, and what goes into their prenatal development, what comes out of their early childhood is very much a reflection of what is going on around them. So here again is where we can show and we can learn from beyond the biomedical model exclusively as a picture of health, but really how all of this comes together for the health and wellness of our children and our society as a whole. I will highlight this one line from the executive summary, which sort of points to what I just said. Despite advances in pediatric care and public health efforts, poor and racial ethnic minority children still face a disproportionate burden of chronic disease, premature death, and preventable illness. Having said that, there are improvements that the report highlights, as well as areas in which we can focus our efforts to improve. I'm sorry, I keep doing that. Advance that, please. So just again, to set the context, the demographics of children in Philadelphia. Children ages 0 to 17 make up about 21% of the population. This next pie graph shows the distribution, and it's fairly equal among different age cohorts. So there's about 35, a little bit less than 36% less than 6, 30% between 6 and 11, and 34% adolescent. Next slide, please. Having said that, there is a significant reflection of the ethnic and racial diversity of our city. In this case, Black and non-white Hispanic populations of children make up nearly 70% of our pediatric population, or population of children. White and Asian and other make up the remaining. Next slide, please. And this is just a geographic reflection of where the pediatric, so I apologize, as a physician, I refer to it as pediatric population, but it is children population less than 18. But this shows where the concentration and where the distribution of the pediatric population is throughout the city. You can see Center City is the lightest rectangular area on the edge of sort of where that line is where the College of Physicians sits. And across the south, west, lower north, and northeast is the remaining distribution. Advance, please. So Growing Up Philly breaks it down into trends and patterns of specific indicators, and those are looking at health outcomes, health behaviors, clinical and preventative care, the physical environment, and social and economic factors. And we know through literature, through data, and through all of our experience that many different experiences during childhood can shape and impact future health. And namely, of those that are reported on in the report is poverty, nutrition, exposure to environmental hazards, and other environmental issues. Our panel, we have found really among the most impressive, if you ask me, representatives of some of these topics, including clinical and preventive care, nutrition, adverse childhood events and trauma, and the built environment and green spaces. So I will certainly let them discuss that even more. Sorry, advance slide, please. Looking at some of the health statistics, just as big pictures, here we see the child and adolescent mortality table from the city of Philadelphia. You can see that prematurity and prenatal conditions account for the highest proportion of deaths among children. And just second to that is homicide, which is, I found, quite notable. And if you look down, there are sleep-related infant deaths, congenital anomalies, cardiac conditions, motor vehicle crashes, suicides, drug intoxication, and then other medical issues such as cancer and infectious disease. What is also quite concerning is that Philadelphia has the highest pediatric mortality or child mortality rate of the large cities. And you can see here on this graph that we are our per 100,000 rate is 71.6. The national rate, just for context, this is 71.6 is 45% higher than what the national average is. And the national mortality rate is 49.5 per 100,000 deaths for children. Next slide, please. Looking at some of the other contexts in which our children and our city grows, childhood poverty is another significant issue. Many of us know that Philadelphia is the poorest of large cities. The federal poverty level in 2018 was set at just a little bit less than $26,000 a year for a family of 4. The total population of all ages for children, you can see in Philadelphia, which is the orange bar, is quite high, significantly higher than both the state, which is the state of Pennsylvania in blue, and the United States as a whole, which is gray. That is particularly notable across all ages, and 30% are children less than 5. Next slide, please. If you look closer at the poverty rate broken down by race and ethnicity, you see the highest rates are among Hispanic children, at 49%, nearly 50% of the population of non-white Hispanic children are living in poverty, whereas 32% of the population of Black children are living below the poverty level. Next slide, please. Moving into preventive care. Immunizations is actually one of the areas in which the city has been successful over years of increased overall immunization rates. Our most recent data shows 69.6% rates of immunization, and the national average is just about that at 70.4%. Dr. Feemster will discuss this and other related to preventive care in her presentation. Next slide, please. And this is just a snapshot of children up to date at different school ages. And overall, almost all are above 90% other than varicella. And then just kind of looking at if all 5 are up to date, that's the only time where we drop below into the 70s. Next slide, please. This too is setting the context for Dr. Kilby, who will be discussing WIC programs. But you can see here, obesity is a significant issue among children in Philadelphia. And if you look at the proportions, Black children are noted to be, Black females have higher obesity rates, followed by Hispanic females. Sorry, Hispanic males. Sorry, you can read the graph, but I mistook. Hispanic males have the highest proportion, followed by Black females. My apologies. Next slide, please. And this, again, Dr. Kilby will expand upon, but families receiving public health benefits in the last year, more than 50% of the pediatric population and families receive WIC benefits in the city of Philadelphia. Next slide, please. Dr. Rajan will be speaking to trauma and adverse childhood events. And there are so many different factors that go into that, but I just wanted to show some of the what I found to be very interesting data from the report. Depressive symptoms were generally on an unchanged trajectory up until 2017, and we've seen a marked increase in depressive symptoms, especially among teens. Breaking that down among race and ethnicity, we see that Hispanic and white populations had a significant increase, as did Black, but to a lower extent. The rate of rise was more steep, but the overall number is still lower. Next slide, please. Building on that, what is also very concerning is suicidal ideation and attempts. There was a marked increase between 2017 and 2019 for both. And again, when you break it down by race and ethnicity, Hispanic populations and Black populations, especially females, demonstrated significant increase in suicidal attempts. Also breaking down among other vulnerable populations, we see LGBTQ teens have a significant proportion of suicidal ideation and attempts among all children. Next slide, please. And finally, green spaces. We have Ms. Maitri Roy here from Bartram's Garden, and she will expand more on this. But we all know, and certainly I think any parent during the COVID era can say how important outdoor spaces and how important green spaces are. And this is something that I think most of us, excuse me, from Philadelphia have always been very proud of how many gardens and parks we have. This map shows really that that's very concentrated in certain areas. And if I was tech savvy, I would overlay the distribution of children map on this map, and you would see that the outdoor space is not really where the children are the most populous. And that is something that Ms. Roy will discuss with us through Bartram's Garden. Next slide, please. So I apologize, I've taken a bit too much time, but I really want to now lead off into our speakers. As I've said, we're very, very proud and pleased that each of these speakers have been able to join us today. I will start. Dr. Kristen Feemster is a pediatric infectious disease physician. She is a health services researcher and a public health practitioner. She received her bachelor's degree in environmental biology at Yale and her MD and master's in public health at Columbia before she came to CHOP and Penn. She has been on faculty at Penn since 2010. She then transitioned to a full-time public health role as the medical director of the immunization program at the Philadelphia Department of Health. and she is now the Global Director of Medical Affairs for pneumococcal vaccines at Merck Research Labs. Next, we will have Dr. Linda Kilby. Dr. Kilby joins us from WIC. She is a registered dietitian with a doctoral degree in public health and a master's degree in health administration. She is the director of the federally funded supplemental nutrition education program for women, infants, and children in Philadelphia County, which is the largest single county program in the Commonwealth. She graduated with a bachelor's in food and nutrition from Columbia Union College in Tacoma Park, completed her dietetic internship at Howard University in Washington, D.C., and received a Master of Science in Health Administration from St. Joe's University in Philadelphia and her PhD in Public Health from Walden University. Next, we have Dr. Sonali Rajan. She is an Associate Professor of Health Education in the Department of Health and Behavioral Studies at Teachers College at Columbia University. She also holds a secondary faculty appointment at the Department of Epidemiology at the Mammen School of Public Health, also at Columbia. Dr. Rajan is a school violence prevention expert who studies gun violence and adverse childhood experiences. She holds faculty affiliations with the CDC-funded Columbia Center for Injury Science and Prevention, the newly formed Columbia Scientific Union for the Reduction of Gun Violence, and the Institute of Urban and Minority Education. And finally, but certainly not least, Ms. Maitri Roy is the Executive Director and Landscape Architect at Bartram's Garden. She was the National Historic Landmark and the home of the famed 18th century botanist John Bartram. I know there are some people at the College of Physicians who are big fans. Maitri leads the restoration and transformation of Bartram's Garden as a vibrant civic common and garden for Southwest Philadelphia residents and a showcase river garden for the city and region. Prior to Bartram's Garden, Ms. Roy led public space revitalization efforts through her work at the Pennsylvania Horticultural Society and the City of Boston Parks and Recreation Department. So with that, next slide, I will leave it to them. Just a last minute encouragement to ask your questions. Really, the strength of these presentations are based on the interaction we have with our audience. In this case, we have to do it virtually, but please ask all of your questions because chances are 10 other people have the same question. And please join us at the section of Public Health and Preventive Medicine. We always love to have new members and bring new issues to the table. So with that, I will let Dr. Feemster take over.
And thank you so much, and good evening, everyone. Very happy to be a part of this panel. Look forward to the discussion. I am going to talk a little bit about preventing infections in children. Takes a neighborhood. And go to the next slide. You know, one of the reasons I love infectious diseases is because of an interest in ecology and how we interact with each other in our surroundings. And so if you think about infections, you know, they're caused by viruses, bacteria, these microbes that are everywhere. They're in our environment, in our bodies, on our bodies. And, you know, some of them do good things and we need them. Some, of course, can cause infection, and especially for children. You know, infections are a common cause of illness. And I think now, you know, as we saw when we looked at the kind of burden of different health outcomes in children, infections are a smaller proportion comprise a smaller proportion of health outcomes. And I think that's largely because some of the successes we've achieved through prevention policies. But I think important that we are not complacent about these prevention strategies. So, you know, really, when I think about the prevention of infectious diseases, they really do significantly contribute to healthy communities. And so in the next few minutes, I hope to really talk about how neighborhoods matter when it comes to infectious diseases risk, both exposure and outcomes, and then also to talk about implications for policy with a focus on vaccination, which has been something that's been a significant focus of my work. All right, so next slide. And excellent. So you know, it's hard to talk about infections without acknowledging where we are right now. You know, we are all impacted by COVID-19, and I think that our current pandemic does provide ample opportunity to consider the impact of both environments and community, and the challenges of implementing prevention and mitigation measures. So, you know, this does represent, you know, a new emerging infection for our community that, you know, this is something that's largely spread through interaction with others. And we've seen differences in disease incidence, certainly by community, you know, there's, you know, by state, by region, as well as by, you know, individual neighborhoods, as you can see in this map of Philadelphia, looking at the number of cases per 10,000 residents in the past 2 weeks. And so this is the perfect platform to talk about, you know, how our, you know, neighborhoods might matter and what is it about, you know, where we live that might impact exposure and disease risk. Next slide, please. So, you know, firstly, you know, we even just think about how COVID-19 came on the scene. You know, this really is at the foundation about how we interact with our environment. You know, coronaviruses, they're a very large and common family of viruses that can infect both humans, people, and animals. And sometimes this can happen with influenza as well. You can have these viruses that infect animals, and then they can change just enough to then also cause infection in people. And because, you know, as communities, especially in you know, urban areas, as we interact more with our natural environment, you know, for our own needs as a community, we have more opportunity to interface with animals and have some of these exposures happen. And so when we look at the coronavirus that causes COVID-19, it likely initially emerged from an animal, and there was an opportunity for this exposure. And then as a new infection, you know, it has, you know, spread through communities around the world. And there are other examples, of course, of this as well, related to coronaviruses as an example. Next slide, please. So, you know, there are also other examples of infections that we derive from our environment. So, you know, there are mosquito-borne illnesses, you know, and so we think about mosquitoes that we see, you know, all the time, and that we, and, you know, we put on mosquito repellents to prevent bites, but they also can prevent infection. So things like Zika virus, West Nile virus. And as there are more places for mosquitoes to breed in, you know, in our neighborhoods, then exposure risk can happen. Next slide. Lyme disease, another excellent example, you know, and other tick-borne illnesses. And so, you know, as climate changes, a range of ticks change, and then that can impact our risk of exposure. And then there are also food-borne illnesses as well. You click again, please. Should not have included so many animations. And that's another example of, you know, a kind of environmental exposure. You know, there are, you know, always reports of infections from and outbreaks related to different food items. And that's largely from, you know, contamination that can happen through farming, et cetera, where you might have bacteria that's, you know, carried in an animal that can then contaminate, you know, food that we do eat. So, you know, we are all about the environment in which we live, and we interact with it in so many different ways that can contribute to the potential for infectious diseases risk. So certainly how we interact with our environment is very important in that way. Next slide. And then another important one, I'm sorry, antibiotic resistance as well. You know, that's something that we talk about, you know, concerns about things like MRSA, the Staph aureus that's more resistant to antibiotics as an example. You know, some of that really has arisen because of the antibiotics that we give to animals as a part of, you know, farming and agriculture that, you know, may help us produce more meat, but also can contribute to antimicrobial resistance. So just another implication of how we manage and interact with our environment. Next slide. Not really. Okay, excellent. So for that reason, and I like this, this is just a CDC kind of, you know, slide or image about One Health. And I think this is very true. It's the idea that the health of, we are really connected to the health of our shared environment, and that, affects children certainly, and also, families, and that health of the community overall is really important and impactful for children. Next slide. So the other very important way, of course, in which our environment matters is certainly related to the socioeconomic environment. And we started talking about the very beginning of the review of the Get Healthy Philly report. And, especially in the setting of COVID-19, we really can see examples of how this really, really matters. And so, our socioeconomic environment can also impact infectious diseases risk. And we might think about kind of neighborhood and community factors and with other health outcomes, but it also really does and can affect infectious disease risk as well, and one's experience after developing an infectious disease. So certainly we know for COVID-19 as an example, infection and mortality rates are significantly higher among African American and Latino patients compared to white patients. This has been reported quite widely in both academic literature and media. There have been disparities by race, ethnicity, education level, as well as immigration status for other kind of side effects of this pandemic, including unemployment, income loss, and food insecurity, as employment has been disrupted, and access to different social services has been disrupted. And there have also been differences in receipts of some of the kind of mitigation strategies that we've had, including unemployment assistance as an example, and other supports offered through the CARES Act. So, why do we see some of these disparities, and what can we do about them? So next slide, please. This is, concern for disparities in the setting of a pandemic is not new. In fact, in the year before the 2009-2010 influenza, the H1N1 pandemic, we all remember about 10 years ago, of course, did not result in this such significant disruption, but it was, a pandemic that did cause a significant number of influenza cases. This author here, Blumenschein, and his team published a conceptual model that described potential sources of disparities that reflect both, I think, the impact of individual characteristics as well as social and environmental characteristics that may be shaped by where one lives, and then also considers how that might influence potential disparities in one's experience with something like a pandemic. And so as an example, you can see here that differences that might be based upon income or education or occupation, race and ethnicity as well, that might influence disease risk or access to healthcare services. Any of these things may result in some disparities in either exposure to a virus. Here this model was about influenza, or susceptibility to contracting the virus, or once exposed, getting really ill. Disparities in treatment once disease has developed. And these can have an additive impact as well, and you can get these disparities in illness and death. Click, please. It's another animation slide, I'm sorry. And so then when you're considering neighborhood characteristics, I think, there are important factors to consider as well. So crowding is certainly one. Certainly the closer that we are together, you have something like influenza or another respiratory virus, the more opportunities there are for transmission. So depending on what housing availability is like, for example, depending upon public transportation, location of medical care, so how easy it is to access medical healthcare services may also impact risk, and then of course other occupational factors. Another click. I think there's something on the bottom. And then yes, these are more individual characteristics, but age, nutritional status, other comorbidities, vaccination status, obviously very important for flu, for influenza, and you can also consider vaccination at a community level. And so, that's, the reason that we've seen such a significant impact in related to vaccination is because of its, population level impact. And one more click, yes. And then, of course, access to regular healthcare, so that helps maintain or prevent poor outcomes related to different comorbidities, insurance, et cetera. So, many of these social determinants of health that we started to talk about at the very beginning, can all really play a role, I think, in one's experience, especially during a pandemic when I think a lot of our infrastructures are really, really stretched. Obviously with COVID, things have been significantly disrupted, such that I think you can really uncover, many disparities that may have already existed. Next slide, please. So, there have been a few other models that have also been proposed to explain how neighborhoods can matter when it comes to infection. So obviously we already kind of talked about likelihood of contact with other infected persons related to crowding or transportation. But there have been also, other considerations that have tried to think about, so we all have our own kind of individual kind of characteristics, but how does that work within a neighborhood? And so just as an example, at the time of the pandemic, specific to children, we looked at disparities in disease risk for pandemic flu and found that kids who were covered by Medicare, so they were eligible for public insurance, but they lived in higher income neighborhoods, had some of the highest risks of infection. And we, wondered why we had that observation. And so, one model is that could help explain that is this relative deprivation model in which, even if you are in a highly resource setting, if you yourself have limited access to those resources, then they're not going to be, you don't have access to those resources. And so that might even contribute to more disparities. There's also kind of a social deprivation model, a relative standing in which there could be differences in social supports within one's community that may impact disease risk or how one might experience infection. I think this is especially important for children. In the setting of COVID, for COVID-19 thus far has largely affected adults, especially older adults, and now more younger adults, but has really not impacted children as much, at least directly. But I think children have been significantly impacted by the effects on their families and in the disruptions that we've seen related to COVID, not being able to go to school, disruption in some of the other social supports. And then lastly, there's another model called broken windows that has been applied to different health outcomes. A paper from, it's probably 20 years ago now, looked at this idea of broken windows and risk for different sexually transmitted infections. But this idea that a built environment could influence behaviors that can increase the likelihood of exposure to communicable diseases. But these are all different ways to think about how where we live matters when it comes to infectious diseases risk. Next slide. So, the most important, what really matters here, of course, then is to consider, how these models can inform prevention strategies. What can we do to keep communities safe for children? We are doing so much now to prevent COVID that have required significant disruptions, but this is not the only infection that currently affect our communities and will not be the only pandemic probably that we'll see. So, policy change is going to be important, of course, policies to I think more of a focus on public health infrastructure to improve access to healthcare services and really address these deep-seated disparities that impact a range of health outcomes. And we'll be interested to explore some of this during the discussion. And then, more directly related to infection, what can we do or what do we do to prevent exposure in our environments? We do things all the time to prevent exposure, like washing our food, using insect repellents. And then lastly, I think other key prevention strategies, and one that's especially paramount for children are interventions such as vaccination. And so, that is, especially for infection, a really powerful tool, to keep communities safe, because vaccines are something that work both for an individual and at the community level. And so I want to turn to this topic before I finish. And so next slide. Uh-oh. I lost, what happened? Oh, I'm sorry, I lost my Zoom screen for just a moment, but I'm back. Okay. So vaccination, I think, as we've already talked about in the introduction, really one of our most important public health strategies. They've really been responsible for significant reductions in infections that have been a big source of both illness and death in children especially. And that's largely due to a successful immunization program. And so we're lucky right now, honestly, to live in an era where infectious disease outbreaks had been, until this pandemic, infrequent. And that's largely due to vaccination. We've seen impacts amongst adults as well. Next slide. But vaccination has been successful, but I think we do have some important challenges that we need to pay attention to ensure that we can maintain this public health impact and maintain healthy communities for children. And so, even though we have had, fairly high immunization rates overall nationally and in Philadelphia, there is variation by region, community. Click, please. Region and community. And so you can see variation by state. And if we, looked at immunization rates over the, city, there are, pockets of lower immunization rates in some neighborhoods than others. Click, please. Another important issue is a rising vaccine hesitancy, especially as immunization schedules have continued to expand. It's even been named as one of the top 10 threats to global health in 2019. And then click, please. What's very important to the here and now are significant reductions in routine immunization rates that we've seen during COVID. And I think especially as we are considering children go back to school, winter is coming, this really could potentially result in a resurgence of some vaccine preventable diseases and outbreaks of other things like whooping cough, on top of what we're experiencing with COVID. So vaccination and changes in rates, really all of these things really do matter. And there have been plenty of studies that have demonstrated the pockets of under vaccination are significantly associated with vaccine preventable disease outbreaks. And I think what also is very important to keep an eye on and focus upon right now is this issues of trust related to vaccination, and I think other public health measures that we've seen emerge in our current setting can impact the likelihood that everyone will engage in them and can reduce the effectiveness of mitigation measures. And we can go to the next slide. And I think as an example, we can have seen that a little bit when we look at reported intention to receive a coronavirus vaccine, when one might be available. And so a significant proportion of people, when asked, at least right now, or this is from mid-May, whether or not they'd get a COVID vaccine, many say no. And there are differences both by race and ethnicity as well as age. And I think that probably underlies some of the many different reasons why people might have questions about vaccines. And so let's go to the next slide. So I just want to very quickly focus on vaccine hesitancy as just I think a really important discussion to have when we're talking about maintaining the benefits that we've seen from vaccination and their contribution to healthy communities for kids. So vaccine hesitancy is certainly not new. And you go to our the History of Vaccine website on the College of Physicians. I think there's a lot of great information on this. But vaccine hesitancy has been around since the first vaccine has been introduced. We can click. And so, there were vaccination leagues established in the 19th century, largely around some concerns about vaccine safety and effectiveness, and especially because the initial vaccines that were introduced against smallpox, they really were not the kind of way the vaccines worked was really not well understood, even by those who developed the first vaccines. In fact, the first vaccines were developed before we really had germ theory. And so, there are concerns about vaccine safety, belief that, diseases are really due to one's hygiene practices, rather than whether or not you receive a vaccine. And then there also started to be more concerns about public health and medicine overstepping boundaries. So, pushback against compulsory vaccine policies. So all of these themes also resonate today, but they certainly have been around since the history of, throughout the history of vaccines. Next slide. And then we can see, as I pointed out, kind of where we are now. Next slide. So I think where we are now is because of many different things. And so one is a consequence of success. So, as we have less experience with some vaccine preventable diseases, there have been more concerns and questions about the need for and the safety of vaccines. And, you do get a vaccine when you're healthy. And so if you're less concerned about, what you might be preventing, there just may be more questions about vaccine safety. Next slide. And then I think we also are living in changing times, and I think we can see plenty of examples of that now. And so, there is a rising distrust related to, many of our institutions, including public health, and kind of the scientific denialism. We can see that related to things like climate change, where there's kind of a debate about things for which there probably shouldn't really be any debate. The sky is blue, is it not blue? Earth is round, is it flat? There more conscientiousness regarding that, natural is better. And the idea that, a vaccine is not natural. And then most importantly, I think rapid spread of information and also just misinformation. And, I think we are all bombarded with information from all fronts. And sometimes it can be very difficult to know what is reliable and accurate and what is not, or information just changes as we learn more. And, that can be raise issues related to trust as well. Next slide. So, I think that is where we are. And I think that this has certainly come out very recently in, other recent outbreaks that we've experienced. So the measles outbreak that we had here in the US in 2019 that largely was focused on communities in and around New York City. A lot of that was largely fueled by, a lot of kind of anti-vaccine activism, and also the dissemination of a lot of misinformation. And so you can see really impactful that can be even in the setting of an outbreak, that message that, this vaccine is not safe, even though a vaccine is really needed to stop the outbreak, really still resonated. So I think this will be my last slide. So, I think, so this is where we are, and I think where we need to make sure we continue to work and focus is really make sure we understand how we all make decisions about vaccines, and if use that information to help address immunization gaps and address hesitancy. And so very quickly, I think this model does really highlight how multifactorial vaccine-related decision-making can be, and as well as how complex it can be to address. But largely, and this is a model that was developed by a vaccine hesitancy working group from the World Health Organization. But I think there are three primary realms. So complacency is certainly one, and that is just related to how concerned one might be about a vaccine preventable disease, and so then how you might prioritize getting a vaccine over other things. Convenience is certainly related to how easy it may be to get a vaccine. If you call a clinic, do they tell you have to wait a month to get an appointment? Or are only the appointments during your working hours? Is it expensive? And then confidence, I think the big one, really related to trust. And confidence either in the safety of a vaccine, the information that you're being given, the recommendation that you're being given, et cetera. And you can click a few times I think all of this also lies within a lot of context about how, what we've been talking about, history, media exposure, politics, what we believe in general about health, what our neighbors do. And so, these are all things that I've tried to understand and focus on, and think just as a community, making sure that we, support access to, reliable and accurate information, and do what we can to kind of rebuild and maintain trust. And that will contribute to healthy communities. So I think that's all I have. I probably went over 10 minutes. Oh my God, I sure did. Sorry. Okay, next.
Thank you so much, Dr. Feemster. Next, we have Dr. Kilby. Dr. Kilby, take it away.
And you can go to the next slide. It's all there. The mission of the WIC program, as you probably know, the WIC program is the premier nutrition education program in the country. And although it's considered a supplemental program for pregnant, breastfeeding women, infants, and children up to the age of 5, in the most recent 6 months, it has probably become the source of the foods that they're eating. And as a result of so many people being without jobs or being reduced in the amount of time that they can work, that we get an average of 30 new applicants every day asking about the WIC program. Now, here in Philadelphia, there are 9 full-time WIC offices, and prior to COVID-19, there were 5 satellite offices. And up until the 23rd of March, we were still seeing people every day in these offices. But I had to make a decision how best to prevent the spread within the offices, and also how to continue to provide service to the people who were in greatest need. And our offices are strategically placed throughout the county. And so people were coming, and we were saying, okay, we can serve you, but you can't come into the office. That became a problem. Let me back up a minute. In November of last year, Philadelphia switched over from WIC checks to WIC e-cards. Now you'll say, that's fantastic. That was a big help. Well, it was fine as long as we didn't have COVID-19. Once we entered into COVID-19, we realized that we could not remotely load these cards. So the people were still having to bring their cards to the office so that they could be loaded. So we looked at how we could best serve our population and keep our staff safe. And we came up with the plan of WIC drop boxes. WIC drop boxes allow the clients to bring their cards, drop them in the box. The staff regularly empty the boxes, they sanitize the cards, they reload the cards, and they either mail the cards back to the client, or in some cases, the client would wait for the card. Well, we did that for the month of May and June and July. And May and June, we probably mailed over 9,000 cards. In July, we mailed over 10,000 cards. And this meant that the nutrition professional staff were interacting with the parents over the phone. They were doing what the new thing is, telehealth. Everybody was doing telehealth. And so we were providing service to the parents and mailing it to them. Well, that has become a problem because in the last 2 weeks, we have had more and more people who don't receive the cards that we've mailed to them. And in fact, today we received envelopes from the post office that have all the paper in them, but guess what's missing? The card. So the darker part of society seems to have figured out what's going on, and they're removing cards from the client's mail, the people who are in deepest need. So right now, we are in the process of reopening the offices just so that people can receive benefits. And what the goal is to reopen the office so that we can have 6-foot separation and see probably, depending on the size of the waiting room, 5 to 8 people, one person per family, as we try to continue to provide service. This is a challenge because right now we are servicing over 49,000 participants in Philadelphia County alone. Philadelphia County is the largest single county program providing WIC in the Commonwealth. And so it means that we have to work very hard to keep things moving, to keep the staff safe, to keep the participants safe, and to keep the offices safe. So once we start to have clients come into the office, what's going to happen? We're going to have to sanitize the offices more often. I just got in the mail the sanitizers that allow me to pour liquid in and spray out, I'm not sure what it sprays out. I think it's like a mist that can sanitize in like 6 minutes. And this is one of the ways we'll try to keep the offices, again, safe. The thing I think that's important for you to know about WIC right now is that there are several reasons that people can be enrolled in WIC. One of them is residency, one is income, but one of them is medical nutritional risk. And we have so many children who are at risk, many who are overweight. We have lots of children who still are on bottles instead of drinking from sippy cups. So we see a lot of dental caries. We have a lot of premature newborns. We have a lot of pregnant moms who don't come for prenatal care until the 6th or 7th month. And although we promote and support breastfeeding, so many people think that we only give formula. So we have to do a lot of education. In the process of changing the way we have done things in Philadelphia over the last 6 months, we have found that talking to moms while they're at home instead of them being in the office has been more relaxing. Their stress level is down because the children are right there. They're not having to think, okay, I'm here with this one and I've got to get home before this one gets off from school and gets to the house, or I have to go and try to figure out how I'm going to pay for the gas bill or the electric bill, or just what's next. A lot of stress is felt by the people who we provide service to in WIC. And the newest little people with stress are our preschoolers. You'd say, well, why is a preschooler feeling stressed? Well, we're hearing from parents that the children are crying because they want to go to school. And when they can't go to school, they want to see their friends. And then one little girl last week, the mother said, I don't know what I'm going to do because she's crying because she hasn't eaten her lunch and it's time for the next class to start. So you see the COVID-19 crisis has affected the children and families at all levels. And we're just trying to keep everybody calm, and we're trying to continue to provide service. Now, on the other side of the coin, as a public health program that provides rotations and internships for students, we're trying to help them because they were stuck. They had nowhere to go when it came to rotations for community. So we have started virtual ones, and this has been very helpful. You say, well, they don't learn a lot. They learn a lot. We do case studies. We talk about the WIC program. We introduce them to everything that's done so that they can go out into the community and be helpful. One of the positive things about the Philadelphia program is that, as you know, we are a city of neighborhoods, and we have multiple ethnic and cultural and racial groups throughout the city. Throughout the years of service, we have worked very hard to employ from within these groups so that we teach them about WIC and they share it with the community. I don't know how many of you have had to use translation services. One of the problems we run into is when we're dealing with translation services, many times it's a male that's talking, and that's culturally inappropriate for our female clients. And too often they try to translate word for word instead of interpreting the idea that we're trying to get over. So by hiring from in the community, we're helping to make sure that our babies, our preschool children, our moms, all get the information and get it in a clear, concise way that they can understand. So we support breastfeeding. We provide formulas of all types for children with special needs. We have certification processes with all 5 delivery hospitals so that when new moms are in for prenatal care or for delivery, we get that information right away and we get the children enrolled. My time's up, but I'll answer any questions that you have for me later. Thank you.
Sorry. Thank you so much, Dr. Kilby, Dr. Feemster before her. We now move into Dr. Sonali Rajan's presentation on adverse childhood experiences.
Okay, hi everyone. I hope you're all doing well, and thank you for joining us on this Wednesday evening to hear about all of this wonderful work. I'm so grateful to Kristen and Priya for having me here today, so thank you. So I'm going to be talking about adverse childhood experiences, the prevalence, gaps, and sort of opportunities in which we're missing right now in this context, and then a few thoughts on next steps. So we'll go to the next slide. So right now, this is just to kind of get us started and orient us a little bit, but this is a graph from the Centers for Disease Control and Prevention. I really like this chart because what it really hits home is that adverse childhood experiences, and I'm going to define what those are on the next slide, but what they do, you can sort of see how there is a progression. You experience them, and then without any sort of intervention or support, adverse childhood experiences can subsequently lead to disrupted neurodevelopment, social, cognitive, and emotional impairment, ultimately a higher likelihood of engaging in higher risk behaviors, disease and disability, and then early death. And so the implications of having experienced these potentially traumatic experiences is significant, and we really want to think about how we're screening for them, how we're intervening and supporting children who have had experiences, and what we can, and the roles that we can play in mitigating this public health issue. So if we go to the next slide, I have spent a little bit of time here just defining what ACEs are. So ACEs is sort of the shorthand word or acronym for this. I'll say that instead of adverse childhood experiences, just for the sake of clarity. So ACEs persist as a public health issue in the US. About 2/3 of adults report experiencing at least one ACE. And it should be noted that many people do experience multiple ACEs. And so that is something we really need to consider as well. And really by definition, ACEs are conceptualized as stressful or traumatic events that impact the healthy development of children through adolescence and into adulthood. And historically, I'm going to talk a little bit about this as we move forward, but ACEs have historically focused on issues like household dysfunction, child maltreatment. Those are really sort of the origins in which ACEs existed. But now ACEs are better understood to include a wider range of events, children who have experiences with the juvenile justice system, youth experiences with bullying, things like that. But there's a little bit of ambiguity around what comprises ACEs or not, so I do want to spend a little bit of our time today talking about that. I'm in my office and the light goes off if I don't move around, so apologize for that. All right, next slide, please. So right now, and many of you probably do this in your own practice, ACEs the screening process for ACEs predominantly take place in clinical settings. So what happens is you have a child, or sometimes we actually screen for ACEs among adults as well, but you have kids who are interacting with our healthcare system in some form, and it might be for a variety of reasons, but they're interacting with our healthcare system, and so a nurse or a physician or maybe a social worker, someone will conduct a screening, and it's really a checklist. So yes or no, typically about 12 to 14 ACEs that get screened for most often. Yes or no, has this individual experienced any of these ACEs? And often the parent or the caregiver will respond, but sometimes for slightly older children, they, like adolescents and emerging adults, they can actually respond themselves. The idea of screening is simply so we have that information, and then we can actually help intervene and better provide support for these kids. So I'm focusing kind of on the kid part right now, which is really where my work is. But the purpose of screening, in addition to just informing us about what's going on in our communities, also means that then we can we can then refer children to interventions and other support systems. So for example, social workers or a grief counseling program or whatever the appropriate intervention might be. The challenge here is that the ability to make these referrals is completely contingent upon a community's resources or a family's access to these kinds of interventions. And so the good news is we have a lot of interventions available that might address a wide-ranging number of the health issues that are closely linked to ACEs, but many of these are not readily available to the communities who need them most. So I really always like to emphasize that part when we're talking about this, because that is a huge gap from a practice perspective that I have a responsibility to fill. And so as someone who does a lot of education-oriented work, I think a lot about the role of schools and the way schools can potentially help fill that gap. Okay, next slide. So as I was mentioning, ACEs comprise a whole set of different types of experiences, and the ones I'm listing here, child maltreatment, divorced parents, death of a primary caregiver, these are sort of the common ACEs that get screened for most frequently. Okay, next slide. So just to provide a little context for the ways in which ACEs exist in Philadelphia, I just wanted to look up a few statistics to share with you. I kind of love this. There is this, it's called the Philadelphia ACE Project. It's been going on for a few years, and they've actually sought to examine the prevalence of ACEs and community level adversity among Philadelphia residents. And so in their work over the past few years, they've actually been surveying adults, not children, but it gives you a sense here of sort of the prevalence and the wide persistence of ACEs. So for example, over a third of residents living in Philadelphia report experiencing emotional abuse, physical abuse. Over 40% have reported witnessing violence as they were growing up. And well over a third of residents report experiencing 4 or more ACEs, which is a lot. I would say these numbers are broadly speaking on par with national numbers, but some of like the witnessing violence and the multiple ACEs are certainly a little bit higher than we typically see nationally. And we do see this as a broader trend that urban areas do experience disproportionately more ACEs than other areas. Although that again might be a screening issue, so a little bit of a public health data challenge there. Okay, next slide. So we are living in this just extraordinarily challenging time right now, where we are also posing questions like you see here, which is something like COVID-19. Is that something like that? Should that be considered an adverse childhood experience, and what are the implications thereof? And if you go actually to my next slide, I'm moving through these faster than I thought I would, but maybe that's good. So I wanted to highlight COVID just very briefly, because COVID has played a very interesting role from the perspective of ACEs. First and foremost, because of COVID, a lot of ACEs that were already in place have been amplified. So experiences with domestic violence, child maltreatment, household dysfunction, a lot of that has been exacerbated during this time. But the nature of COVID has also amplified increased job loss, increased economic instability, increased housing instability, unfortunately and tragically increased illness and death among family members. School closures and disruption in schooling has absolutely resulted in increased instability for families and children. There's also been an observed uptick in gun violence, and I highlight this here. You can see this headline I pulled. This is really the work that I spend most of my time doing, is really thinking about how community violence and school violence go hand in hand. But the fact that we are seeing really a convergence of public health issues coming to head, right? We see COVID-19, we see gun violence, which is a public health issue, coming together. So these are some real challenges we're trying to consider in our work and in our thinking. All right, next slide, please. I did want to highlight, so in that context of gun violence as an ACE, so this is a little bit of work that I've been doing with some of my colleagues here at Columbia, where we have really been trying to advocate for, in our writing and in our work, the importance of capturing gun violence in childhood. So exposure to gun violence among kids as an adverse childhood experience. There are multiple experiences that ought to be considered ACEs, but currently many are not captured by existing screening measures, and gun violence is one of these. And I've actually shared this in various forms with my own students, and when I share this with my students, they are like, how is that possible? How is that even how could we not already be doing that? But this is a real missed opportunity from a screening perspective. In the work that my colleagues and I have done, we've really used the existing literature, the existing evidence base, to draw some very clear comparisons and similarities between exposure to ACEs and other ACEs and exposure to gun violence, how exposure to gun violence can have significant impacts on a wide range of health outcomes among children, the need for interventions and resources to support children who have been exposed to violence, gun violence, as well as children who have been exposed to other forms of ACEs. So this is an opportunity here, again, to bring together, to say, let's think about how are we operationalizing and defining ACEs? What does that mean for us as practitioners, for educators, for those of us who are interacting with children and in different systems? And how can we expand our definition of ACEs to be a little bit more comprehensive? Okay, I'll go on to the next slide. So just very briefly, just to kind of summarize some quick thoughts. So again, the takeaway from a lot of this work is to say, how do we expand our definition of ACE to be more comprehensive of all youth experiences? Another thing that I think is really important to just highlight is that ACEs are not just isolated moments. So screening and subsequent efforts to intervene and to support children and family have to reflect that. Systemic issues, poverty, racism are also sources of trauma and must be accounted for in our screening of ACEs, but also in the way in which we screen for ACEs, which the screening process by itself may be traumatic for children and their families as well. So we have to be mindful of that. I do like to highlight the poverty and racism piece in particular, because these issues, as I mentioned at the beginning, drive whether or not a child has access to comprehensive care, support, intervention, other resources. And this all has critical implications for the ways in which ACEs impact children in the long run. So I think I just have one more slide, just my contact information, and that's a picture of my 5-year-old who I hope is eating dinner right now. So thank you for having me, and I'm happy to answer any questions or engage with folks on social media.
Thank you so much, Dr. Rajan. That was very informative and interesting. And we have come to our last presenter, and again, certainly not least, Ms. Maitre Roy from Bartram's Garden.
Hi, everyone. I'm really delighted to be here. Thank you to Priya and Kristen for inviting me. I'm certainly don't have the qualifications that the panelists have, and I speak to you from the perspective of managing a public space and observations that we have around how it impacts the lives of our neighbors that are mostly using the space. Bartram's Garden is about 50 acres in if you can go to the next slide, in the southwest part of the city. It's right along the Schuylkill River with an extraordinary vantage of the tidal Schuylkill. And it's a publicly owned space owned by the city. And we've partnered with them. I work for a nonprofit that has been essentially established by descendants of the Bartram family to preserve and share the legacy of the Bartrams. Next. The garden is located in, like I said, Southwest Philadelphia, where the community largely was highly industrialized and then went into, in the mid 1900s or so, essentially went into deindustrialization and decline, resulting in lots of abandoned land, lots of sort of toxic, polluted land. And it was only recently, just last year, that the oldest refinery in the city, actually in the nation, that stopped its production work, which is directly across from the garden. Next. The garden, as I said, is on the Schuylkill River, and it was, this is one of the most industrialized parts of the city. The Schuylkill essentially was the sewage dump, the sort of pollutant dump for most of the industry that was established along the southern end of the Schuylkill. And there was instances in the 50s when the Schuylkill would be seen on fire for 2 or 3 days at a stretch, because so much garbage and grease and so on would ignite, sometimes self-ignite, and it would take days for the fires to go down. Go to the next slide. There's a number of factors that have changed, and some things are positive. Because of the Clean Water Act in the 1970s, the restrictions that were imposed along industries that were directly, dispensing all of their waste into the river's health has significantly improved. And it's an exciting time, that so much so that there is a really big interest now in the Southwest to think about sort of restoring the river's edge, restoring water quality, and restoring land adjacent to the river so that there can be more public space for active recreation, passive recreation, and so on. I bring this up because the southwest part of the city, if you looked at its statistics, is one of the most underserved part of the community of the city of Philadelphia. And in that context, we as a historic house and garden have been really examining our own role as to what we should be thinking of and doing in service to our community. Next. We are starting to see ourselves, as much as we continue to preserve and promote the Bartram legacy, which is an extraordinary accomplishment in the 1700s of the Bartram family that established farm and a horticultural enterprise here at the garden and provided plants to the rest of the world from this 400-acre establishment. Today, we're down to about 50 acres, but we still do that important historic preservation work. And yet, even beyond that now, we see ourselves as a classroom and the family room of a community where dense urban fabric that surrounds the garden means that we're possibly one of the only green spaces easily accessible to particularly the public housing that's right next to the garden that has about 2,000 residents, of which about 700 are young children. In that context, if we can move to the next slide, we really see ourselves as moving from being a historic house and garden to morphing into what we see ourselves as like a civic common, where our neighbors are really welcome. They are invited in. They have become a part of our decision making, our ability to sort of provide programming that's really relevant to our neighbors. So we've become a place where there's a lot of music, there's a lot of gardening. There's a lot of fun that happens at the garden, along with a couple of programs that I want to mention that are really go to the heart of some of the needs in the community. One is, as you see here, the idea that this is a place where you can find opportunity to be one in nature, to learn about the natural environment, to learn about ecosystems and what a healthy ecosystem means to your life as a resident in the community. So we have about 10,000 school children that are at the garden year round. Some of them are coming back every week. We have 50 high school students that are there year round from our local high school. And if you move to the next slide, one of the things that we're really excited about is an urban farm where these 40-some students are focused on the farm, about 10 on the river. These students are working essentially to learn all aspects of farming, including running the farm stands, running the greenhouses, and so on. And these students are really immersed in farming that's rooted in an African diaspora, essentially growing food that is culturally valued, culturally sought out in the community. So this project has been going on for about 10 years now, and every season we put in about 15,000 pounds of food into the community. The other aspect is essentially this neighborhood has lived riverfront but never really known it, and it's an extraordinary stretch of the river, and we've been really focused on getting a lot of activity out on the water's edge, including lessons in fishing, lessons in kayaking and rowing and so on. And if we can move to the next slide, we are soon going to be part of the Schuylkill River Trail. So in preparation, we have a fleet of bikes that you can sort of sign out as a family or as a community group. We have a stable that I'm really excited about that's going to be set up at the northern end of the trail pretty soon as a way for you to exercise on the trail, as a way for you to explore the trail, and actually access places that Southwest hasn't been connected to before. Get to Center City, get to museums, get to jobs, get to healthcare, and so on in 20 minutes on a bike. So next, I want to tell you about a couple of really cool projects that will maybe entice you all to come to the garden. We're getting ready for next year to launch a floating classroom in the Schuylkill. We're excited about this project. It'll be as if it's a looking glass into the river, a way to study the river's health, the way to study the river's chemistry and so on. And then moving to the next slide, we're also really excited about a partnership we have with an organization that focuses on river restoration, and we'll be establishing a mussel hatchery at the garden to produce river mussels. These are not the kind you eat. If that disappoints you, these are the kinds that actually heal the river. So I'm really excited that we'll be introducing these back into the Schuylkill sometime soon. And the last project on the next slide that I'd like to share with you that I'm really excited about is that we're looking to build a nature-focused pre-K childcare center right adjacent to the garden, where the curriculum, essentially the garden will be the classroom, the curriculum will be nature-driven, and we will be working with 200 families, 200 children, 200 families from the immediate community, and integrating them with lessons in the environment from a very early age. This is something I'm really excited about. Green spaces are working really hard right now. These are very challenging times for green space caregivers because we're short-staffed and visitation is off the charts. And I'm hoping that out of this pandemic that we're in will come a really strong realization that green spaces are like any other infrastructure that cities have that need investment, that need care, and they all need focused attention so that they continue to provide the resources to our communities. So I'll stop there.
Thank you so much, Ms. Roy, and to all of our panelists. That was fantastic. We have been getting comments through the chat box and also some questions. So for everybody on the call, please, if you have questions, bring them forward. Again, in a live format, we can always sort of point you out, bring you up to a microphone. In this format, you have to do a little bit extra work of just typing it in, but we have the experts here ready to answer your questions. And again, this is also my personal favorite part of these events, because we can really hear from our community and some of the issues that are most salient to you and some of the questions that you have, which is the goal of the program in general. So let me just start. Panelists, perhaps you can unmute because we will be kind of discussing all together. One of the first questions we got is actually for Dr. Kilby. Dr. Kilby, are you currently hosting WIC services in the CUA, which is Community Umbrella Association sites? Not sure if that was an idea as well.
Sounds like a good idea. Right now, I'm not doing anything in satellite offices. We're only doing providing WIC in the, actually it's 10. We're opening one more on Monday in the 10 WIC offices. And we will hopefully get back into our satellite offices after the first of the year.
Very good, thank you. I have another question. So I will just repeat again. Unfortunately for us as city members, the Department of Public Health, as you can imagine, is busy. And we could not have them on, they couldn't join us for this call. So I shared some of the data from Growing Up Philly. But Dr. Feemster, being both a pediatrician and a member of the Department of Public Health most recently, I'm going to direct this to you. So you might be able to save me. So the question, first, there was a comment. Thank you for a fantastic and enlightening presentation. You mentioned in the opening that Philadelphia has the worst infant mortality and was the poorest of the largest cities, if I heard you correctly. What do you think are some of the contributors? So I was trying to look and remind myself if in fact the Philadelphia has the worst infant mortality in the country. I do know on that one bar graph, we were the worst of those cities listed. But Dr. Feemster, can you speak a little bit to what you think are the contributors to infant mortality in the city of Philadelphia?
Yeah, that's a big question, and I think it's honestly multifactorial, and so I certainly would welcome other inputs as well. But I think some of it could be related to some of the other challenges that we've been talking about. Stress, ability to access prenatal care services. And, I think there have been a few recent kind of reports about, differences even in, maternal experience, especially for women of color in some large cities. So, I think it's probably multifactorial and could be related to many of the other social determinants that we've been talking about. I mean, certainly Philly is one of the poorer cities. It might also be contributing as well. This is not one of my, foci, but yeah, I would welcome other inputs as well. But I think it's a combination of a lot of factors.
Can I open that up to the panel? Does anybody else have any thoughts? I would myself agree that it is multifactorial. It is marked though. I don't know myself what I mean, it makes sense that and we know this, we are the poorest of all of the large cities. That said, only 21% of our population is children, which surprised me, I will tell you, when I read the report. I thought it would be more. But the fact that of those 20% of our total population, 70% are basically Black and brown children, Black and non-white Hispanics. That, you know, there's a lot. What I have found as an emergency physician and a public health person is COVID has sort of, you know, peeled the onion a bit and really shown a lot of what we have all known, both in the medical field, the public health field, and the research field, of some of these major disparities. And it has made the issues, I think, undeniable. But there are certainly, I think every single member of the panel could speak to that, because I think each one of you represent an impact that on children's lives. Whether or not those are perinatal and infant mortality specifically, it certainly goes into prenatal health and maternal health, and all of that is so intertwined. Keep your questions coming. We really like this part of the discussion. Let me move on. So we have such a diverse group of panelists encompassing so many areas of traditional and non-traditional public health partners. Could each panelist highlight a partner we should bring to the table when tackling these issues, who would be with the greatest impact to the most vulnerable children?
I would say that the community is very important. Too often, I think that we talk about what they need, when in actuality, when we go and talk to them, we will find out what they would like to have in addition to what they need. And one of the issues that we see continually is that so many families don't understand the importance of early prenatal care. So they don't come to WIC even until, like I said, 6th and 7th month. So we have lost all that time to provide education as well as medical care. So I would say that the community stakeholders are really important when we're talking about what needs to be done in the community.
Dr. Rajan, do you have any thoughts about that?
Yeah, I mean, I think this is one of those things where we have to understand and recognize how many of these health issues are also just interrelated. So by addressing and thinking about, you know, like we were talking about infant mortality, and that is tied to, you know, a mother's exposure to her trauma in her life, and the ways in which she then feels comfortable seeking care, and the ways in which we also, when we talked about racism, and like the ways in which that drives the way we look at individuals and the way we pathologize them. So I guess my answer is it's sort of a non-answer, but just sort of underscoring what I love about this panel actually is that it's highlighting how there are all these disparate health issues, but the value of thinking about children as whole children and sort of thinking about their needs all together and how these issues are related to one another, I think is actually so critical. So I love actually that this panel is doing what a lot of panels don't do, which is bringing together people from different disciplines. That's my husband in the background telling me that my son ate his dinner. So that's keeping your hearing. I apologize.
Dr. Feemster, who do you think that we should include or bring to the table when it comes to vaccine hesitancy, vaccine acceptance, any kind of preventive care when it comes to not just infectious diseases, but general health?
Yeah, that's an excellent question. You know, I think related to vaccine hesitancy, I would agree that I think community partners are going to be very important, because I think that messaging about vaccines needs to come from other trusted voices in a community, and not just, I think that providers are kind of viewed as, their recommendation matters. That is what at least kind of the research says, but it's not the only thing that matters. And I think to really get at issues of confidence and trust, we have to have, other partners and really understand who everyone is listening to when it comes to information related to vaccines, and to really, work with those other voices. And I think also to really not really appreciate how important the issue of trust is when it comes to public health messaging, whether it's vaccines or other public health messages as well. I think other health outcomes related to kids, because it, many of these issues are kind of complex and multifactorial. I think some of it kind of depends upon what it is we are trying to address. I think in many ways it's kind of all hands on deck and being conscientious about what the issues are and doing a lot of listening, rather than, I think as Dr. Kilby was saying, already kind of deciding what the solution is going to be. And I do think that, there are so many things related to the social determinants that we've all been talking about that are really just deeply seated and like years and years and decades of kind of inequality that is not going to go away overnight. So.
Excellent. Thank you. Ms. Roy, you are in fact, in my mind at least, one of the people that we all want to call, you and your brethren, everything that you represent, that we all want to call to the table. And I think I can speak only from the medical perspective, we have not historically been as collaborative or inclusive of all of the social determinants, but most especially green spaces and outdoor spaces, and the kind of impact on health and wellness that the outdoors can have, not just in terms of all of your programming that you mentioned, so much learning, so much education, so much community engagement, which even it's tragic, but I was just seeing the images like, oh, I remember those days. But who would you say in the discussion of health and wellness of children and really their future, we should make sure to include at the table?
Oh, wow, that's a hard question, because I think of the very many facets of people that we come into contact with. I think parents, like starting that process early of connecting to nature, I think it starts as a child, and keeping that cycle going is really important, and that happens through the parents. We're finding our visitation numbers are off the charts right now, and it's mostly local families that are otherwise, living in 2-bedroom apartments, and there's 3 generations of a family in them, and the garden is like one of those spaces where they can just, kind of be in a environment that's somewhat beautiful and is a little bit of an escape. But the children are there all the time, so we have numbers of children that come to the garden without any supervision. So we have a number of programs that we've started to connect with parents and guardians in some significant ways. And I feel like that engagement is really, really important. I also think that there isn't enough understanding of what these green spaces mean to the life of a community. And I feel like some general better understanding of that with our educators, with our policymakers, with folks that build and design and care for cities, all of those important roles, and giving more focus to green space. I mean, Philadelphia's sort of whole being is based on this idea of a green country town. So there are sort of essentially those principles of green spaces are embedded in the way in which the city was organized, including the first sort of large-scale urban park system that was created to protect our water source, our drinking water. So I think our history speaks to how important these things were in the lives of people at that point. And I think sort of really bringing that back and putting a focus on it now, how public health is related to how we treat our environment is like really an essential lesson for now. That's a long-winded answer, but.
That was a great answer. I appreciate it. Thank you. So I'm going through our comments. So this is a question, and this is a doozy, but this is something that is very salient now with 55 days left until the election. But what are some, so I'm going to summarize a couple different questions. What are some political actions we should take as healthcare professionals and educators? And related, what are some of the asks we need to make from our political leaders in these critical times?
I
Dr.
mean,
Philby, do you want to start? Dr. Rajan, can you please start?
No, I mean, I was actually going to defer to Dr. Rexine on this because I feel like this is really her area of expertise. But voting, registering to vote, talking to your family and friends. I know some people feel like voting is like not that important, but it matters. And not just voting at the presidential level, but like up and down the ballot. I'm not going to tell you all how to vote, but there really is just like kind of one good option right now. So we're gonna go. And so, you know, I think the idea is like, that's one very important way of being civically engaged and having those conversations with the people you love and the people in your life to make sure that they know how important it is. Even if they're not engaged on specific issues, they probably have or know or are close to children who are in schools and who their schools are impacted right now. And we have a Secretary of Education who is nowhere to be found actually as schools currently reopen. So when we think about how so many people in all of our lives are being impacted, that's where our vote matters. So I say this to my students too. I just think that right now in this moment certainly is very, very important. And then obviously advocating for specific things and specific pieces of policy or positions that your local stakeholders and elected officials can speak to. But anyway, I said I would defer to Kristen, and then I started talking. So. But that's what I would say.
I'm going to just echo what Dr. Rajan is saying, you know, making sure that we are getting out there and speaking to people and registering to vote and actually taking action. And you can vote safely in the time of COVID. You can request a mail-in ballot. You can, you know, show up early, wear good shoes, wear a mask. And, you know, I think that we here at the college have a really critical role in playing, you know, we are experts and we bring together experts and we bring together the community and we highlight the needs of the community. And, you know, I think as what was demonstrated across this panel is the need for funding for many of the great initiatives and programs and policies that are already out there. You know, we don't need to always recreate something new, but we need to fund what we have. And so that would be, you know, making your voice heard.
I think it's also important, Kristen, that our children understand about the whole voting aspect. So many times we don't talk to them about it. And I find that even we're mandated to ask WIC participants if they're registered to vote, and if they're not, to provide them, you know, with the information. And what I have learned is that they're not even aware. Somehow or another, they didn't take civics classes, or they weren't in class when they discussed this, and they didn't understand the importance of voting from your local community right up to the, you know, to the national, and how important that is. So I think it's important for us. I talk to my grandchildren about voting. The younger ones can't vote. But if I start now talking about it and the importance of it, then by the time they get to that point, then hopefully they'll make the good decision.
I would say I completely agree. And I think generally speaking, for many of the topics that we're discussing, youth engagement is really, really important. So maybe thinking about kind of working with education as a partner, I think related to kind of civic engagement, but also, talking about scientific literacy, just, so many things that I think are important and can be addressed through youth engagement that can really promote, kind of support and appreciation for our environment. How do we think critically about all of this information that we're receiving from all of these different sources? How can we ensure that we're active and engaged citizens? So I think that's not a political action per se, but I think another important activity.
I think we've all seen a change in investment. And it becomes, I will say, as someone who clamors a lot about a greater need for investment in certain areas, and I think each one of you reflect an area that needs significant investment, with the knowledge that the return on that investment is tremendous and so long lasting. I think some of us struggle both in local politics and decision-making of how the vote is won. And of course, that is something most especially now with an upcoming election, that is something that we need to all understand and make aware. How do we make one of the ideas within the paradigm of public health is that politics is a reflection. In a democracy, politics is a reflection of the values of the community. And so each of you have educated us and I think enlightened a lot of us on the different aspects that affect our children and affect the generations coming behind us. But how do we make what our values are known to those who are our leaders and in the world of politics, not just the ones, not just kind of, and not to diminutize this at all, but not just click a button next to a name, but really make sure that the name on that list is someone who reflects our values. That's a big question too, but I open it up to the panel.
So true.
No takers? All right, I don't mean to stump you. I don't think there's a true answer to that in the sense of there is an of course answer to that, but it is the struggle of all of us in our work to make sure that not only are we addressing the people in front of us, those of us who are clinicians, those of us who are forward-facing frontline people, but I think where the role of public health comes in is that all of us who are engaged with individuals, engaged with the community, also take into our head, how do we turn around and make sure that other people see what we see? And that's something that is very salient to me in the emergency department. And it basically has driven my career so far. We need everybody to see what we see. And I think it will become an easier discussion. So that is also why we strive so hard in the public health grand rounds, is to bring these different perspectives and bring the diversity of expertise to the table, because that's where you can pass on what you see.
I think, I was just gonna say, that's so right. I mean, this kind of dialogue is crucial, but I think what's really challenging now is that with polarization, I think it's become easier for people just to kind of stay in their camps and only kind of hear what kind of amplifies or supports what they already believe. And I think it's being able to bridge that is going to be the really big challenge. And I think kind of moving forward on some of these issues and communicating values, but.
I agree. I think that's a call to all clinicians, teachers, practitioners. We're the ones who know how to talk about things and try and educate people, and where we have to hold very true and tight to science, because science is always right. That's my take. Let me just scan through our other questions. If anybody on the panel as I'm doing this has any other comments, please. I don't want to miss anybody. Let me just see. Ms. Roy, thank you for your very informative report. What type of decisions are the neighbors invited to share in?
Ah, great question. So we are actively trying to get neighbors to become part of our board, become part of the governing structure of our organization, hire people from the neighborhood as staff. We have a committee of community residents that constantly inform our programming, what types of programming that they'd like to see, so that we can be relevant and attractive to our neighbors. We're in the middle of forming a youth a group of youth, young people in the neighborhood who are artists and entrepreneurs to help us make sure that our programming also appeals to them. So that's another group that we think is really important to hear those voices. And hiring presenters, like we don't do all our programming ourselves. We really mostly provide the space and the environment. And what we are really excited about is when our neighbors come to us with programming ideas and that they would like to sort of bring on themselves. So really providing access to space, resources, some staffing help so that programming that's generated within the community gets featured at the garden. So if you're interested, we're doing a comedy show in a couple days that features local comedians, and it's going to be streaming. And so we're really trying to like highlight local talent, local Southwest artists and so on.
That's very exciting. That's fun, actually. One message, hold on. Sorry. I think, so we will wrap up around at 7:30, but let me, I actually had my own questions. So this goes back, Dr. Feemster, to your presentation. I thought the idea of relative deprivation model is really interesting. And so I do a lot of work with vulnerable populations, and we see over and over that stigma plays a huge role in accessing services. Do you find that so using that model of low income family living in a high income area, and now with the idea of so many in our community and so many across the city are dealing with unemployment, perhaps for the first time ever, do you feel that stigma plays a role in accessing services even for children? And are there any sort of efforts, activities, things to counter those kinds of behaviors? And Dr. Kilby, I suspect you can chime in on this as well.
Yeah, that's an excellent question. I do think that stigma can play a role here. Certainly, a feeling or sense of, I can't, go in here. I don't belong. A perception of feeling kind of unwelcome when trying to access services in a certain area, whether real or perceived. So I do think stigma can be one contributor to that idea of the relative deprivation model. In addition, maybe to just services not being readily available in general. Yeah, and so stigma, and you can certainly see. I think especially now a loss of employment or anything like that results in a lot of anxiety and potentially feeling and self-conscious about this change, and whether or not anyone else is passing any judgment. I think that perception can still be very powerful and impact the likelihood that you are have to walk in and say, I want to sign my child up for a clinic visit, etc. Yeah, so how to address something like stigma is that can be a difficult thing to do. I mean, certainly I think it is important for, you know, any resource in a community to really consider how welcoming and open they are, you know, how accessible their services really are. And so, you know, do they have things that really to consider, you know, a range of things to make sure that their setting is welcoming, you know, and I think that in some ways, people might not even be thinking about the issue of stigma. So it might be important to kind of just raise it, right? And, you know, we're all like, things have changed for all, you know, for many of us. And so we'll think a little bit about, you know, how we may be perceived by the people in our community, by everyone in our community. So maybe engaging business groups or organizations, you know, organizations that might, you know, communicate with clinics, businesses, groups, et cetera, might be one place to start. But, you know, otherwise, some of it I think comes from one side, you know, it's like more of a personal feeling. That might be a little bit harder to address at the population level. But I'd be interested in seeing what other people think about that.
I think it's very evident in it's something as simple as grocery shopping. Mm-hmm. Because people who live in poor communities go out of their community to shop because they know that they can find a better quality of food when they go out of their community. And but it's not always about rich and poor. It's about different cultural groups. And I'll give you an example. 3 years ago, our budget was cut significantly, and I had to make a decision to close an office. And my administrative office and one of my largest offices is located at 1300 West Lehigh, right between Temple Hospital and Temple University. And I closed an office that is exactly 1 mile east on Lehigh Avenue. And I said, well, the clients can come just 1 mile down to the other office, which was large enough to accommodate them. But what I learned was Germantown Avenue is a line of demarcation between the Hispanic community and the African American community. They didn't cross that line easily. So many of the Hispanic families chose to travel a longer distance to Aramingo and Tioga, where they felt more comfortable culturally, than to come to a larger office that could accommodate them, but was in a different cultural community. So it's not always poor and rich. Many times it's cultural.
Dr. Rajan, do you have anything to add to that? I think, you know, the concept of stigma and the concept of feeling comfortable in asking for things definitely is intertwined with traumatic experiences and the sense of safety that plays into adverse childhood events and experiences.
Oh yeah, absolutely. I mean, I think a lot about the ways in which, so a lot of the work that I do and others are and really others are doing, I'm sort of just following in their footsteps, but this notion of what does a trauma-informed space look like? And that means creating the space in which children and or their families and or their teachers feel like they can ask and advocate and, you know, prioritize the well-being of the student, for example, without feeling like there's going to be some sort of repercussion disciplinarily wise or otherwise. That tends to occur among children of color in particular. So we really want to think about the ways in which, you know, we're normalizing. I mean, we saw, right, how prevalent ACEs are. And so if they're that prevalent, think about all of these people that are walking around with these experiences that they have lived with, and we have not as a society provided them with the resources or the care or the support. And to me, this is where the onus historically always been placed on the individual and not on the systems that are in place, and frankly that we have as a responsibility as our communities to serve and take care of our children, and by extension then supporting them to grow into adults who then can do the same for others. And so I don't know, I'm going on my soapbox a little bit, but I believe very strongly in the notion of creating the opportunities and the space for, and by doing that, what I mean is it could be just simply really asking each child, how are you doing? Checking in with them, not presuming things about that student, which we do in classrooms and out of classroom spaces every single day. So, I think a lot about how we interact. I think about that in my own work. How am I interacting with my students? Am I being mindful of that? I'm not saying these are easy things to do. I think this is just all a part of the way in which we have to think about how we engage with one another. And so anyway, I'm just sort of agreeing, I think, with everything that's been said, but I do feel like given how given how much so many of us carry, so many folks carry, so many families carry the burden of trauma that they carry, I think we always have to enter a situation with a level of kindness, compassion, integrity. It's like these are the things that have to be valued and modeled in every aspect of our system. So I think a lot about that in the school context, but I think it's important that carry out in other ways.
So we are a minute over. I feel like we could go on and on and on and have discussions on how to change the world as we all want to do. But let's close out with a final thought from each of you. So in the words of my dear mentor, Jeremy Nowak, and he wrote a book with Bruce Katz, and he's from Philadelphia, by the way, who his sort of quote that I almost live by now is, power belongs to the problem solvers. And it really, problem solving can happen in hyper-local spaces on up. And so I ask each of you, what do you think is the problem you see in front of you that you want to and can fix, and how can we all help you do that and work together to do that for the sake of our children and their wellness? Dr. Feemster, would you like to start?
Sure.
I'm going to go in order of your speech.
I mean, honestly, fundamentally, when I think about the things that keep me up and, that I worry about them, I just feel like we all need to be a good neighbor, and that's what everybody needs to do, and that would, by being a good and conscientious neighbor, address a lot of the fundamental issues that we've been kind of talking about. Honestly, so I'll say that, and to not be scared of the power that we do have, the power of our voice and the power that we do have. I did see a quote related to that I thought was very, that really resonated. I think sometimes we are kind of scared of that, and but not to be scared of that, so that we can make change. But yeah, be a good neighbor.
Excellent. Dr. Kilby? Oh, I think you're on mute. Hold on.
I think that we have to care for our children. We have to love our children, and they have to know that we will care for them. So many of our children live in unsafe areas, and I just think that we have to find ways to make it safe for them. One thing that we didn't talk about in any depth was obesity. And one of the problems with the children in the inner city is that they don't have anywhere where they can go and be in the green space and get exercise and breathe fresh air. So I think we have to do something to make a change there. And I don't know that I can do it all, but I just feel very strongly that it's something we have to it has to be put up on that bulletin board so we can check it off eventually.
Thank you. Dr. Raju?
I loved what you just said. The power belongs to the problem solvers. I love that so much. I just wrote it down so I wouldn't forget it. I think that's great. I just gonna, echo what the others have said. I mean, I really, from my angle, I do think a lot about how ways in which we view children, the way we think about them. If we think about children as sort of as an entity, as an entire being, person, all their social, emotional, physical needs, that will then inform the way we engage in our practice, right? The ways in which we discipline them in schools, the way we prioritize funding for after-school programs, right? The way we think about access to green space, the way in which we think about should we be arming our teachers with firearms. Like, these are the things that we, if we actually thought about the well-being of children first, then that would inform better policy, better practice. And so my call is always to do that. And I yes, I say that as a mom, but I say that also as someone who works with children and has for many, many, many years at this point, and knowing, I think we all know that, right? Fundamentally, what children need. It's not rocket science. It's pretty intuitive. And I think if we trust that, that for me is very important. So I will end my thoughts with that thought.
Thank you. And finally, Ms. Roy.
I would say
A lot already, but.
Well, I would just say that I hope that spaces like the garden can be available, can really aspire to be a safe space where children can be, and where families, children have the opportunity to just, be in nature. And an unsafe space is equally dangerous. And so investing in making these spaces safe, these spaces friendly and welcoming is really important. So just having a green space that's unkempt and neglected next to you is quite harmful for your health. And so ensuring that spaces like this are cared for, and that it just becomes part of the way we expect our green spaces to be in our city, like raising the bar on expectations, I think, across the city is going to be what I'm hoping that we can move towards.
Thank you so much. Well, I cannot thank you all enough. This has been a tremendous panel. I think it's always a salient discussion. It's an especially salient discussion now as some of our children have just gone back to school. Some of us are trying to navigate all of the nuances that come with that, but also all of us are thinking about what all of this confusion and all of this that we're all going through is affecting our children, and how and what we can do to help our kids, help our community, and do our part. And so I thank you all for really sharing your expertise and knowledge, and really bringing some great enlightenment to the table that I think we can all move forward with, because the goal is not to just sort of show the problems, but really come together and work together to address those problems. And I think Dr. Feemster mentioned one of the hardest things is just identifying a problem. And so here we have you all kind of handing it to us on a platter. So thank you for that. And thank you for taking your time to join us. Thank you for all of those attending. This has been our first virtual event, and so I appreciate your patience with us. I'm realizing the lighting in my room when I don't have natural light is a whole other thing, so I apologize if I'm in shadow. But we really are very thankful to everybody. And again, for everybody on the call, and usually we would have this in person, and it's followed by, quite frankly, like a little munchie hour where we can continue the discussions. We don't have that opportunity now, but I do hope that you will continue to engage with our panelists. We have their handles, their social media aspect, and their emails, both on the slides and I think in your pamphlet. And certainly we always want you to engage and join with us at the College of Physicians, particularly through the section of public health, but even just to come back and visit these days, now that the museum is back open. So with that, if there's no other comments from the panelists, thank you all for your time. Thank you for the IT help from the college. I will bid you all good night.
Thank you guys so much.
Thank you so much.
Hey,
This was really
bye-bye.
fun. Good night.
Bye, everyone. Thank you.